that helped define the risk in women who had cancer in the lymph nodes. Now, previously, prior to in the START study, we would often give chemotherapy to women who had cancer in the lymph nodes after surgery. And this essay now helps to define who should get chemotherapy in patients up to 3 positive lymph nodes. So we can spare chemotherapy for a lot of women who test low risk on this panel. So the cutoff is 25 for those of you that are familiar with the test. There is a nuance here that so the validity of the score is more so in postmenopausal women than in premenopausal women. In premenopausal women, the essay didn't seem to help. So anyone who is, say, 50 or below is going to benefit from chemotherapy if there's cancer in the lymph nodes. But for women that are postmenopausal, we certainly have a tool now, and we can spare chemotherapy to a lot of patients. So that's an exciting piece of news, some new development. As far as stage 4 disease goes, I think the big picture with stage 4 disease is that we are not defining cancers just by the presence of the estrogen receptor anymore. I mean, this is how we've done things for 25 years, but the science has moved, and what we're doing now is, studying the DNA of the cancer cell through a platform that's called next-gen sequencing. And what that does is it, is going to identify most mutations that a cancer cell, has or carries, and it, sort of differentiates the cancer cell, from a normal cell. And there are products that are made from these mutations that we can actually target, through drugs. So a drug that I mentioned earlier in this talk, is called epilisib. It's also called Piqray. So this drug is now currently approved for patients who have a PIK3CA mutation. This mutation is present in 40% of estrogen-positive breast cancer. So if we didn't study the DNA of the cancer cell, we wouldn't have the option, for this drug. So the more options we have, the better. So currently this drug is approved, in second line. So after failure of, let's say palbociclib, ribociclib, or something like that, we have the option to use this drug. It increased, progression-free survival, which is the time it takes for the cancer to regrow, or to become resistant to the drug. It almost doubled it as compared to fulvestrant. So it's given with fulvestrant, which is a shot that blocks the estrogen. It's given as a pill. The main side effect is it's sort of as a hard drug to take in my experience, it causes a lot of nausea, vomiting, sores in the mouth, especially hard on people with diabetes because sugars can go up. So we do have to keep a close eye on folks that are taking this pill, but we try to, manage them as best as we can. So it's an exciting drug, to have, which adds to, the options. And like I said, the more options we have, the better. So the other approval is also for olaparib, which is a drug that I just talked about. It's also now approved, in stage 4 disease. There is a cousin drug which is called talazoparib. Both of them are targeting the BRCA mutation. So again, the field is really moved to trying to study the DNA of the cancer cell and then look for these mutations and target them. So, so we need to know if the cancer cell has a BRCA mutation. We need to know if a cancer cell, has the PIK3CA mutation. There are mutations called the ESR1 mutations where, certain drugs will not work. So it's important to get that piece of information. And interestingly, we actually have 3 different sets of drugs where they are, tumor agnostic. So we don't really actually care what type of cancer it is. As long as we find that change in the cell, we can use the drug. So, so immunotherapy drugs, for instance, there's a drug called pembrolizumab, which can be used if the tumor mutational burden is over 10. Now, tumor mutational burden is just the number of mutations that a cancer cell will have, per length of the DNA. And that number is, 10, mutations per megabase. So that's 1 million bases. So if you have 10 mutations within that length of DNA, then you qualify for immunotherapy, and it doesn't matter if it's breast or colon or lung, so that opens up more options. And same thing, with a test called MSI, if the MSI status is high, then we can use immunotherapies for that. And lastly, there's a mutation called the NTERK mutation. There are 2 drugs approved in that category. It's a very infrequent mutation in breast cancer, but even if it's 1%, I think it's worth looking into. So for stage 4 disease, if I see a new patient today, I am going to order the next-gen sequencing test, get that information so I have more targets. I think my initial treatment is unlikely to change because most of these drugs are approved in second line, but it would definitely make a compelling case to use those drugs in second line if I had that information handy. So that's kind of the big picture in stage 4. I think that as far as the historical drugs go, as far as things like fulvestrant are concerned, or estrogen receptor degraders go, there is some excitement in that department because there are some newer drugs coming out in that. But again, the focus is mostly trying to move past the estrogen itself, but look at how a estrogen feeding cancer cell works and try to block the machinery that then causes the cell to grow and proliferate. What time? Do we have more time?
It is 1:20, so we do have quite a few questions.
Okay. So I'm going to stop here. I could go on for an hour and a half on this topic, but I would like to entertain your questions. I know we have a big audience.
Okay. One of the questions is, someone is asking, I had bilateral, and you might have to repeat my question because they might not hear. I had a bilateral mastectomy, so all of my breast tissue was taken out and a lymph node. What are these cells that can turn cancerous? I'm on tamoxifen and do not like the side effects, and I can't understand if I need it.
So it's a very good question. So the question is that a patient has had both their breasts removed, so bilateral mastectomy, and they're on tamoxifen. And why are they on tamoxifen? Because both the breasts are gone, so why should they even care about breast cancer? So, that's a very good question. So the thing is that we are developing technology to look at the presence of cancer cells in our body that we cannot detect on a scan. So where we are today is we can do a CAT scan or a PET scan, and we can try to figure out if someone has cancer or not after they've had surgery. But there are limitations. We can only pick up something that's maybe, a couple of millimeters on a CAT scan, and on a PET scan, it has to be bigger than 5 millimeters. So anything smaller than that is not going to be visible. And something that's, a millimeter may even, have 10,000 cells in it. So it only takes one cell to make more cancer. So And unfortunately, we don't have the technology yet to find that one cell. So through prior experiences, we know that in women who have, bilateral mastectomy, a certain proportion of them will get their cancer back year 2, 3, or 5, from surgery. The reason that happens is the cancer left the breast before surgery took place. So the cancer had already migrated into the bone or into the lung or liver, and we are unable to find that cancer cell. And the tamoxifen that someone takes is meant to eliminate that micrometastatic disease, as we call it. In all honesty, the majority of women do not, have micrometastatic disease. So if someone had stage 1 breast cancer and they had their breast removed, and if they didn't do anything after that, the odds of them doing okay, probably on an average about 20, they're going to be 80%. So they're okay if they didn't do anything. But if they took tamoxifen, they can cut the risk in half. So the risk of recurrence will drop, from 20% down to 10. So it would be really helpful if we could only give it to the 20 women that were going to have a recurrence. The problem is we don't know who's going to have a recurrence and who isn't. So we have to treat the entire 100 people to save 10, out of the group. So if the group took tamoxifen, they will have half as many recurrences as the group that didn't. And we feel that based on the safety profile of tamoxifen, it can be a pain to take, but it's not a life-threatening. Most of the side effects are not life-threatening. So we feel that the risk-benefit is in favor of taking tamoxifen because we're reducing the risk of recurrence by 50%.
Another question. If on tamoxifen, stage 0 double mastectomy, but 6 cells in lymph node, would you recommend the new drugs in addition?
Stage 0?
Yes.
Okay. So stage 0 breast cancer is actually ductal carcinoma in situ, which is DCIS, which has no potential, to spread. So by definition, that's why it's in situ. It's not invasive. So there is absolutely no need, to put one through all the side effects of the newer drugs, because the risk of no one has ever died of DCIS. The only reason DCIS is treated the way it is to reduce the DCIS, is to reduce the risk of invasive cancer. So half of DCIS will turn into cancer if you don't take it out. So 50% is a high enough number where we feel it needs to be cut out. But you don't ever see DCIS in the bones or liver or lung. It's not possible. So if someone has had a mastectomy, or a double mastectomy for that matter, there would be no reason to even take tamoxifen, because those cells have not escaped the breast because they didn't have the potential to escape the breast. So you are pretty much done. Now, just to kind of further the question, I guess, so would I give one of these newer drugs to someone who has, stage 1 breast cancer? So the approvals we have, are for 2 drugs. One is olaparib, which is in BRCA positive patients. So you would have to have a BRCA mutation, number 1. The other drug, is abemaciclib or Verzenio. And if you look at the FDA approval, both of them are approved in high-risk women. It's because the reason for that is that stage 1 breast cancer, the prognosis is excellent. 97% of women are alive at, 5 or 7 years, So the proportion of women that we need to help is very small. And the toxicity of the drug, if it's high enough, you sort of it kind of, like is a washout. If you help someone by 1%, and if the side effects are 2%, I think it's hard to justify that. So the short answer, I guess, is no, I wouldn't use it in stage 1, and I wouldn't use it for DCIS for sure. But for stage 2, I definitely would consider it.
Another question is, can you say again, or include the spelling of the new medicines?
Yeah, so olaparib, it's OLAPARIB. It's also called Lynparza, which is the brand name. The abemaciclib is ABEMACICLIB, also called Verzenio, which is the brand name. Epilisib is ALPELISIB. And that's called Piqray, so that's the brand name for the drug because of the PIK3CA mutation, so it's easy to remember. So those are the 3 new drugs. Yeah.
Someone was asking a clarifying question too. Is example of the brand of what you speak of Verzenio?
Mm-hmm.
The doctor is an example of the brand of what you speak of Verzenio. Were you talking about Verzenio?
Yeah, so Verzenio is the brand name for abemaciclib.
Okay.
Yep. So that's, we tend to refrain from brand names a little bit, but Verzenio is, more popularly known, yeah, as abemaciclib is more known as Verzenio, correct?
Okay, another question. I had a double mastectomy, stage 2, triple positive, 7 lymph nodes removed, all negative, currently on tamoxifen, Perjeta, and HER2 receptor. Do I still need to consider ovarian suppression for at least 2 years after treatment? Or would you suggest that?
Wow, that's a very good question. So would I consider ovarian suppression in HER2 positive disease? So, we don't have data for HER2 positive, ovarian suppression in HER2 positives. You mentioned stage 2, so I think that's, higher risk. But if you received chemotherapy prior to surgery and you were able to achieve a complete pathological remission, which is a PCR, the prognosis there is very good. So we could do with less than more. Second, most of the estrogen positive cancers tend to be driven, most of the HER2 positive cancers, even if they're estrogen positive, tend to be driven by HER2. So, estrogen is an important component, but what really drives the metastases and drives recurrences is the HER2 component. So if one has had adequate amount of HER2 blockade, then perhaps the ovarian suppression might not be necessary. If it was a purely estrogen positive cancers, then I think it should be. There is a drug called neratinib, which tends to target the HER2, which in subgroup, which is your subgroup, which is estrogen positive, has been shown to improve survival, and reduce the risk of recurrence after completion of Herceptin and Perjeta. So I think that is a strategy that I probably would employ more than ovarian suppression. So I would probably prolong the HER2 therapy a little longer. So neratinib is given for a year, after completion of Herceptin. It too is a difficult drug to take. It causes a lot of diarrhea, but I think that's a strategy where we have more data. Now, can ovarian suppression be done? Of course it can. I think that, it carries more in the way of toxicity for patients. There's more hot flashes, there's a risk of osteoporosis, premature osteoporosis. So it's not without its side effects. And the value that it adds to a HER2-driven breast cancer is probably small in my opinion. So I hope that answered your question.
Another question, I think this might be our last one for time. Someone is asking kind of a clarifying question. She was told that even with DCIS 0, non-invasive, that it should be treated in case another cancer accompanies it. And I think you were talking about DCIS. Is it standard to have that treated?
Yeah, I mean, so I would treat DCIS with a anti-estrogen pill if there was breast tissue left. So if someone had lumpectomy, I think it's like a standard of care to do it after that. If they have a mastectomy and they still have the other breast, then it's standard to do it because you can reduce the risk of DCIS in the other breast. Now, granted that improvement is pretty small, probably on the order of 1%, but there is improvement. So I think that as long as there's breast tissue, anti-estrogen therapy, should be considered. But in the context of someone who's had a double mastectomy, I think it's a kind of a tough sell for me because there is, the breasts are gone, there's no breast tissue, so you can't really get cancer, because there's nothing to make cancer in, which is different than invasive disease because those cells can escape the breast before you take them out. But DCIS cannot escape because it's not invasive. So by surgery, you capture all of DCIS, but surgery may not capture all of invasive breast cancer. So you have to make a distinction there.
One question.
Sure. I'm perfectly fine.
Okay.
Yeah. Go ahead.
Any foods that should be avoided while taking an anti-estrogen medication?
Yeah, so that's a good question too. So so any foods that need to be avoided, in estrogen positive breast cancer. So I think there was a lot of research done on this topic, and phytoestrogens is a type of a compound that you can get from vegetables, and there was products like soy products that were thought to convert into estrogen in the body, and so a ton of research has been done on this, and as far as soy product goes, it showed that it made no difference. And as far as the phytoestrogens are concerned, it's still, the research is not really telling us that it's a bad thing to do, or like it causes more cancers or causes the cancer to progress. So the thing I would avoid is not really a diet, but anything that has potentially estrogen in it. So, things like hormone replacement therapies, estrogen creams, sort of commercial grade products that are, typically prescription. So I would avoid those because, we're trying to get rid of estrogen, and if you put more estrogen into the body, you're just going to feed the cancer. So those are things I would avoid. But as far as diet goes, nothing has really panned out as something we need to avoid.
Okay, last question, promise.
Sure. No, you can go ahead if there's more questions.
Someone's asking for the spelling of the drug that you mentioned for HER2. Not sure if neratinib is the right spelling.
Neratinib.
Neratinib. Can you spell that one?
Yeah, it's Neratinib. Neratinib. Yep.
Got it. That is fantastic. Thank you so much. So sorry
Oh,
for
thank
the
you very
sound
much.
today.
No worries. Thank you very much for your time.